Okay, so we're going to go ahead and get started with the talk here today. Like I mentioned before, my name is Dr. J. Michael Bennett. You should have some information at your tables with some cards and our phone number if you guys have any questions regarding any of the topics we're talking about today or any of the procedures we're discussing today. Then feel free to call and ask me or send me an email. We usually like to record these videos, just have them available on the website. So not only for our patients, but also for you guys if you ever want to go back and look at the talk and see if there was something that you couldn't remember or you want to review. You guys are more than welcome to use the website or review some of the talks that we're going to be going over here. Okay. So today we're going to be talking about the knee, and really the big thing about these talks that I really want to make sure you guys are comfortable not only with the anatomy, but also the physical exam, and also to know exactly when is it appropriate to refer out and when is it okay to just kind of see how they do and treat the sprain or treat the injury and see how their outcome is at that time. So we'll go over some really basic stuff at the beginning, so I apologize if it's kind of monotonous. If you've heard it all before, just bear with me. We'll get to the good stuff at the end. But we really kind of have to make sure that the foundation is there regarding the anatomy and the exam. Okay? So anyway, this is basically some of the gross anatomy dissections I like to put up here oftentimes, because I know a lot of people look at the Netter exams or the Netter pictures, and this tells you exactly what we're seeing in surgery and then what you're going to be really evaluating in the patient. The big structures here, obviously the meniscus. This is the posterior aspect of the knee. Looking at posteriorly, looking at the condyles here, medial and lateral, looking at the meniscus, medial and lateral as well. This is your PCL ligament posteriorly here coming through. And these are your meniscofemoral ligaments. You've got a Humphreys and Weisberg meniscofemoral ligament, which basically kind of hugs that PCL, which actually can add to some of the stability of the joint. You don't hear much about it, but it is a structure that we see. Palpation tendon is also very important with the lateral structures as well as lateral collateral and medial collateral ligaments. Here is the anterior aspect of the knee here. You're looking at Patella tendon. This is the medial meniscus, lateral meniscus, patellofemoral joint up here, lateral collateral ligament, medial collateral ligament here on the inside. This is just one of those typical drawings that you see. So what you just saw were the deep structures. These are the more the muscular tendinous structures of the knee joint. You've got the VMO, or actually the quadriceps, which consists of 4 muscles that insert right around the kneecap. You've got the vastus medialis obliquus, it's actually the largest medial muscular structure here. You got the lateralis, you got the rectus femoris, and you got your quad tendon coming down where it all comes together right here in the kneecap, the patella ligament. You got the pes anserinus here, which actually it's called the duck's foot. I'm going to show you a gross anatomy picture of that here in a minute. That's actually where we harvest our hamstrings from. This is the posterior aspect of the joint. These are your hamstrings. You got your semimembranosus, semitendinosus hamstrings out here on the medial aspect. Then you got your basically your hamstring biceps femoris over here, the long and short heads here. IT band here coming out to the side. So those are just some basic structures here in the knee. This is what you're looking at from gross anatomy standpoint. It's a little dark, and I apologize. Here's the front of the knee again. The quadriceps structures here, lateralis, medialis, rectus femoris, the quad tendon, the patella, IT band coming over here to the lateral side, patella tendon, tibial tubercle, and gastroc. Here's the posterior aspect. This is why things that we worry about are knee dislocations. That's why you really worry about neurovascular injury in the posterior aspect. You got this huge popliteal artery here, as well as the tibial nerve that runs down here posteriorly. Common perineal nerve here that comes out laterally. So if you have a patient that some of these football players that come in, they get hit from the side of the knee and they have a dropped foot. A lot of times they have this perineal nerve is injured or bruised, so they can't lift that foot up. Good news is most of them actually get that function back. It's just a nerve bruise and it just takes time to heal. This is the vessels here that all go to the meniscus and the posterior aspect of the joint. Here is the medial side of the joint of the knee. This is what I mentioned before, the pes anserinus, the duck's foot. They say this looks like a duck's foot, but I don't really see it, but here it is. But anyway, here is the gracilis tendon and the semitendinosus tendon. These are the two tendons that we use to harvest for ACL reconstruction. So we make a little incision over here in the medial and anteromedial aspect of the knee. We take a harvester and actually pull these tendons out and harvest these ligaments, or excuse me, these tendons, fold them over each other, and that's what we use as a graft. This is the sartorius, actually up here, that fans out over it. This is the gastrocnemius here. Here's the lateral side. All the runners out there is your IT band syndrome right here. This is the big band of fascial tissue that comes here on the lateral aspect. A lot of times it rubs up and down against this lateral femoral condyle here and creates some irritation. That's iliotibial band syndrome. This is, once again, the biceps, long and short head of the biceps and the fibula here. Looking at the knee in the front side, ACL, PCL coming across a crisscross section here from the front side. There's a medial lateral femoral condyles, the meniscus. Posteriorly, once again, looking at the PCL coming across the lateral meniscus here. You can see the lateral meniscus has that meniscofemoral ligament that actually extends into the posterior cruciate ligament posteriorly. These are some capsular structures. These are important in injuries that we see in a lot of football players that have any kind of knee dislocation or hyperextension knee injuries, where they actually injure this capsule. So they get a lot of swelling in the posterior aspect of the joint, but they don't have any instability. This could just be a capsular injury, and this is what it looks like in the posterior aspect. This here, once again, shows the vasculature structures in the posterior knee as well as the nerve posteriorly. Once again, the nerve vascular structures in the posterior knee. So once I talked to you guys before about the meniscus and how important it is regarding the meniscus and the vascularity of the meniscus and whether or not you're going to be able to have a successful repair or not, or whether or not it's going to have to be a debridement. This is the meniscus. It's separated in thirds here. The inner third we call the white zone because there is no blood supply in the inner 1/3 of that meniscus. Any tears in that inner 1/3, they have to be debrided back to a stable rim. If you have this pink zone here is the red-white zone, they actually have maybe a potential for healing. So we actually may try to repair those if they actually do have a tear there posteriorly. And then you got the red zone that's in the peripheral 1/3 of the meniscus, and that's where the blood supply is. And you can see the vascularity comes to that peripheral 1/3 of the meniscus with these little tributaries that go to the disc and help supply the nutrients to that disc that allows it to heal. But if you do not have blood supply, it will not survive. So this is just some cross sections. This just shows you, if you're looking at an MRI, this is a coronal view of the meniscus, like Dr. Fritz showed you earlier. This is a meniscus, a triangular shaped structure here in this particular view. This is the blood supply here. All these little vessels here are going in the peripheral 1/3. You don't see them reaching into this inner portion of the disc. So, those are just not going to heal. Unless you have another way to get those nutrients to the meniscus to allow it to heal. This here is looking at it top down. Look at the medial meniscus. You can see how long and how this is kind of a C-shaped type of meniscus. Lateral meniscus is a little bit shorter, kind of looks like an O shape. So assessing the knee joint, okay, starting with just evaluating somebody comes in your office or complaining about knee problems. What do you need to do? Well, first off, you want to determine the mechanism of injury. Did they have a previous injury to this knee? What position was their body in when the injury occurred? Did the knee collapse or did it fall out or buckle under them? Did they hear or feel anything? Did they hear a pop or a click? Could they move the knee immediately after injury, or was it locked or stuck and somebody had to pop it into position? Or did they have to pop it into position like their kneecap or pop their kneecap back into position? Did swelling occur? And where was the pain? Was it anterior, posterior, lateral, medial? These are all important questions and important things to address during the evaluation. Is it a recurrent or chronic injury? Well, you got to evaluate their major complaint. When did they first notice the condition? Is this recurrent swelling? Is it new? Like I mentioned before, does it lock or catch? Severe pain, dull pain? Have them grade their pain as well. Do they feel grinding, grating, or clicking of the knee? Does it ever feel like giving away or becoming unstable? And what does it feel like when you're going up and down stairs, and what treatments have you undergone previously? So you start with observation. Look at the patient, look at the knee. Watch the patient walk up and down the hallway. See what their gait is like. Do they have an antalgic gait? I mean, are they limping? Or are they walking just with a little bit of a limp, or are they walking normal gait? Look for swelling and ecchymosis of the knee. Look at their alignment. Are they knock-kneed? Are they bow-legged? Are they hyperextending? Is their kneecap riding high? One way to look at the kneecaps, having the patient sit at the side of the table and look at their kneecaps and see if they're sitting on the outside of their knees. Sometimes it looks like, we call that the praying mantis or a grasshopper sign, because it looks like the two eyes of a grasshopper looking at you, just because the kneecaps are so abnormally translated laterally. Is the patella rotated inward, outward? Like I mentioned before, tibial torsion just means an abnormal alignment of the tibia. Femoral anteversion is external rotation of the femur, and retroversion is internal rotation of the femur. And these are just all alignment issues in the knee and the leg. But all things to take into consideration. So these are just some basic pictures, and kids are notorious for having just abnormal knees when you first evaluate them, because they're going to be growing up, and a lot of times they'll start out bow-legged like this, then they'll go knock-kneed, and then they'll actually kind of, find a neutral position in between the two. So if you're seeing a child, don't worry about, the mild variances of bow-leggedness or knock-kneed. Now, if it's severe, obviously that's more of a significant issue with things like Blount's disease, or if they have a closed growth plate. But this is more important in adults, okay, or adolescents. So this is just hyperextension here of the knee. This is varus knees, which is bow-legged. This is knock knees, which is also valgus knees. So, do the knees look symmetric? Is one a little bit off? See if there's any weakness or atrophy in the knee. Look for any leg length discrepancies. Sometimes these can actually cause, it starts with from the ground up. If you have a discrepancy in the leg or in a foot position, it can just completely cause problems up and down the whole side of the body. So you always want to look for leg length discrepancies. And I'm sure you guys all look at this too. I mean, you can have pelvic rotations or malalignment of the spine that can actually cause some sort of leg length discrepancy, which actually cause a limping or an abnormal gait as well. So that's something to consider. So palpation. After you observe the patient, you've got a good history, you've got a good idea of where the pain came from or what their mechanism of injury was. Then you go on to the actual physical exam portion and you start with palpation. Just remember all your bony landmarks that we talked about. The medial femoral condyle, plateau, adductor tubercle, lateral plateau. These are all just the bony structures that we talked about earlier and that I showed you a picture of. Just make sure you systematically evaluate each one of those. Then you move on to the soft tissues. Look for any contusions, any defects, particularly within the vastus medialis, the lateralis, and the whole quadriceps mechanism. Look at the quadriceps itself and the patella tendon, because if they can't lift their leg up in the air and they've got a big defect right where the quad tendon is or the patella tendon used to be, a lot of times that can be a rupture. So you want to make sure you find that. Plicas, we'll talk about that a little bit later. That's just an embryological remnant or like a band of synovial tissue in the knee that can cause problems as well. IT band syndrome, collateral ligaments, Pesian psoriasis, you can actually get inflammation of the duck's foot area, and medial lateral joint capsule, hamstrings, gastroc. So you always want to just kind of systematically evaluate the soft tissues. Then you go into the swelling aspects. Is it within the joint or is it extra capsular or extra articular outside of the joint? And extra capsular is actually a joint, intracapsular is actually a joint effusion, meaning a swelling in the joint. A lot of times you can tell this by looking at the knee, palpating the knee, see if it's a little squishy, push it on the kneecap. We call it a ballotable patella. If the kneecap kind of feels like it's floating on something like jello, that means that they've got an effusion in the knee. If it is extracapsular, it can be over the injured structures such as the bursa itself, like a prepatellar bursitis. That's not going to be in the joint. We get a lot of calls in the emergency rooms telling us they got a septic joint or infected joint. We walk in there and the patient just has a swollen prepatellar bursitis. And the way you can tell the difference between a septic joint or a swollen joint and a bursitis is that the patient can move their knee. When they have a severe synovitis or an infection in their joint, they will not be able to move their knee at all. It'll be so painful they will not be able to move it. If they just have a prepatellar bursitis or an inflammation of the bursa of the kneecap, they'll be able to bend the knee, but it'll just have a swelling in the anterior aspect of the patella. So, ligament exam. These are important. This is to evaluate for knee stability. Make sure you evaluate the endpoints, and it's important to kind of evaluate what a stable endpoint feels and what a loose endpoint feels. The best way to do this is compare their knees. Do one side and then do the other. Start with the normal knee, then look at the abnormal knee. MRIs also can be necessary for assessment. Classification of joint instability. We look at usually evaluation when the knee is straight as well as when it's rotated. Also look at translation, feeling the glide of the tibia relative to the femur. And as the damage increases, the laxity in translation also increases. So the higher the grade of strain or sprain or tear, the more injury that the patient has to the knee. So varus and valgus stress, usually this is pretty straightforward. Used to assess the integrity of the medial and lateral collateral ligaments, either ligaments on the inside and the outside of the knee. Testing it usually occurs at 0 degrees. That actually incorporates the capsular structures that I showed you before in the back of the knee. But when you bend it to 30 degrees, it isolates the ligaments. So you want to do it at 0 and 30, just to kind of see if there's a difference. This is just a picture here showing patients usually laying down on their back. You bring the knee out to the side, full extension here, varus valgus stress, then you flex it down to 30 degrees and see if there's any difference. ACL tests, these are important to know, be familiar with. The anterior drawer is usually performed at 90 degrees of flexion. This is where you have the patient bend their knee to 90 degrees if they can. If it's an acute tear, sometimes they're having some problems, they have some swelling, so they may not be able to do this. If that's the point, or if that's the case, sometimes just icing it, putting it in a knee immobilizer and getting an MRI might be the best way as opposed to torturing them. But if they can bend their knee, then 90 degrees to 90 degrees you can do this test to confirm or evaluate an ACL tear. Just basically feel to see if the tibia slides forward from underneath the femoral condyles, and if you don't feel an end point and it slides forward and shucks forward, that means that you do have a lax ACL, and always compare it to the other side. Okay? You can also look at it with internal external rotation to also look at the joint capsule, but that's not as important as just doing the basic anterior posterior drawer. The Ligaments test is a little bit more specific, and this is actually going to be easier to do with the patients because they're not going to be able to bend their knee to 90 degrees, but they can bend it to about 30 degrees. So, this is probably a better test. So basically, you have the knee, bend it to 30 degrees, have the patient relax, and gently try to see if you can slide that tibia forward, and see if they can withstand that. Sometimes they can't even stand that, and like I said before, I've had patients where I can't even do the ligaments because they're so painful and tender and swollen that I just feel at that point I'm like, well, you have a little laxity there. Instead of doing any more tests, we'll go ahead and get a scan and see what it shows. Pivot shift test. This is one of the best tests, but you're not going to be able to do this in a patient that's symptomatic. This is usually done in somebody that has a chronic tear for many years, or they're asleep. Okay, so but basically all we do is really internally rotate the leg. Actually start with the knee extended, internally rotate the leg, and then slightly flex the knee with a valgus stress, and then you'll feel a reduction as the tibial clunks into position, and it's a pretty audible clunk. But it's pretty definitive that the patient has an abnormal ACL. PCL, posterior drawer test, same thing as that anterior drawer test, 90 degrees of flexion. Put your both thumbs on the joint lines and then push posteriorly. If you feel the tibia slide posteriorly past the condyles, that is a positive test. And you can even grade it just depending on how much laxity you have posteriorly when you push it. But that usually will indicate that you have a PCL deficient knee. External recurvatum test also for the PCL. You have the athlete supine. Just grab the great toe and just hold the knee, the leg up. If the tibia kind of falls externally, it slides posteriorly. This indicates a PCL injury, and the knee just looks a little funny. If you grab both legs by the toe, or both feet by the toe, and hold them up and look at both knees, and one of them looks abnormal, that's a positive external rotation recurvatum test. Posterior sag test, also known as Godfreys Test, basically having both knees flexed 90 degrees next to each other, and if one knee kind of sags posteriorly compared to the other one, then that's a posterior sag test. And a lot of times if they contract their quads, that'll actually reduce and it'll actually pull up and you can actually see that. Meniscus tears. How to evaluate a meniscus tear? Well, the McMurray's Meniscol Test is the most popular kind of test used to determine if there's a meniscus tear that's displaceable. I mean, you can actually recreate the symptoms. The leg is moved into flexion and extension while the knee is internally externally rotated in conjunction with a varus and valgus stress. Positive test is usually found with clicking and popping. I find that some patients will have popping and clicking, but if they have pain, then that's really indicative of a positive McMurray's test. So this is basically what it looks like. You hyperflex the knee, you internally rotate, and you come back to full extension with a valgus stress or a varus stress, depending on which side of the meniscus you want to evaluate, if it's a medial or lateral meniscus tear. Another test, a couple other tests you may not hear much about, but they've been described, are the Apley's compression test or Apley's distraction test, and they just differ by one is pushing down on the knee and internally externally rotating, seeing if you can catch the meniscus. Another one is lifting up the leg and seeing if you can internally externally rotate. And if there's no pain, then there'd be no meniscus tear there at that point. Extremity circumference is incredibly important. I do this with all my patients. I evaluate their circumference in regards to their quadriceps and make sure that they're meeting their therapy goals as well as their strengthening goals post-operatively. Change in girth as far as the quadriceps are concerned can occur due to atrophy, swelling, and conditioning. Use the circumferential measures to determine deficits and gains during rehab, like I mentioned. You just have to be consistent on where you do your measurements. I usually do my measurement about 6 centimeters proximal to the superior pole of the patella, and I just stay with that. And that just works for me, but you can do it a number of different ways. Some people will do it off of the gastroc or away from the gastroc anemia, 2 centimeters above the superior border of the patella, or 8 to 10 centimeters above the joint line. I mean, I find that just 6 centimeters works for me. Functional exam, always look at the patient, see what they can do functionally. Can they walk? Can they jump? Can they hop on one leg? This will tell a lot about what's going on within the knee. If they can't hop on one leg, then they may have some underlying instability or they have meniscus pathology. Resistive strength testing also, just to see how much strength they have within the knee itself. Okay, so the patella, these are just basically evaluating the patella. A angle, I'm not really going to go over that. This is not, nobody really uses this as much as the Q angle, which I'll talk about here in a second. Palpate the patella, always palpate above, below the patella on the either side, the medial and lateral side of the patella, because a lot of these patients we see have patellofemoral pain, which is a very, very common thing, and is secondary due to a muscular imbalance across the quadriceps, and we'll talk about that in a minute. Patellar grinding, compression apprehension tests. These are glides and compressions across the kneecap, just to look and see, test the integrity of the patella as well as the patellar cartilage and the ligaments around the patella, and we'll go over those as well. The Q angle, this is basically lines that bisect the patella relative to the anterior superior iliac spine, which is this bone here at the hip, and you just basically get an alignment or an angle between the knee, it bisects the kneecap, it starts in the tibial tubercle and it goes to the ASIS. A normal angle is about 10 degrees for males and 15 degrees for females. Usually if we see patients that come in with multiple dislocations, you always want to get a good Q angle, because this will tell you if they're anatomically predisposed to dislocation in the kneecaps. Like I mentioned before, that grasshopper sign with the kneecaps on either side of the knee when it's flexed, a lot of times they will have a high Q angle, which predisposes them to multiple dislocations. So elevated angles lead to pathological conditions, like I mentioned.